Good afternoon, Chairperson, and good afternoon, everybody. Today, my paper on outcome of single-stage multiple-level soft tissue surgery in the lower extremities of the patient with cerebral palsy with static contracture. Cerebral palsy is defined as a disorder of movement and postures caused by the non-progressive defect or lesion in the growing brain. Prevalence is mainly seen in 2.4% per 1,000 children, which is including 3 to 10 years, mainly male predominance. Classification is based on the Beck's et al. The spastic is the most common, which is involved in 70%, and there's a dyskinetic, which is a thetoid, coriform, and ataxy, and hypertonic and mix. Topographical classification is based on the limbs. There's a diprasia, quadriplasia, triplegia, and hemiplasia. Management is a preoperative assessment by the Thomas test, which is an assessment of the hip flexion contracture, and hamstring tightness can be assessed by the popliteal angle and Felix-Becker test. Tender Achilles tightness has been assessed by the silver square test and port rectum test, which is also called Alice test for the rectus tightness. There's a gross motor function classification has a level 5. In level 1, the children walks indoor and outdoor and climbs stairs without limitation. Children perform gross motor skill including running and jumping, but speed and balance and coordination are impaired. Level 2, children walk indoors and climb stairs holding a railing, but experience limitation walking on uneven surface, and inclines and walking in crowds on confined space. Children have at best on minimal ability to perform gross motor skills such as running, jumping, usually are transported for long distance. In level 3, children walks indoors and outdoors on at level surface with assistive mobility device. Children may be climb stairs holding on a railing, but they may probably a wheelchair man. In level 4, the children may continue to walk short distance on walker or rely more on mobility at home, school, in the community. Children may achieve self-mobility using a power wheelchairs. In level 5th, physical impairment, restrictive voluntary control of movements, and the ability to maintain integrity head and trunk motions. All areas of motor function are limited. Children have no means of independent mobility and transported. In treatment of the CP, there have goals promote the function and prevent the secondary impairment and increase the child development capability. There are various methods we have used, which is occupational therapies, which is mainly the patients improve the daily activities, and physical therapy, which is a stretching exercise for the contractures. Orthosis also can be given for the ninth splint above knee and below knee, which is also reduce the contracture. Interthecal backlon, which is a 100-fold potency more than the oral one, but corrective surgery are used in this my study. In my study, objective has assessment of improvement in the function ability and locomotion by using the gross motor function classification scale score by physical examination. Also to study the different complications associated with this method of the treatment. In my study, there are 20 patients with 17 boys and 3 girls. Mean age has 7 years, 3 months. Range from 4 to 14 years with spastic cerebral palsy. Including criteria there's no other deformity, and excluding criteria in this cerebral palsy with severe profound mental retardation, medical unfit vision, children with mixed cerebral palsy. Patient has underwent the single stage multiple surgery, tendon surgery, which is for the treatment of the contracture in the lower limbs due to the spasticity. Evaluation are based on the pre and post-operative physical examination and findings of gross motor function score. In operative technique, we go through the functional lengthening of a hamstring tendon, adductor tenotomy and release, lengthening of Achilles tendon with using White method, vertical release, and posterior tibial tendon. In this slide, we have seen the medial hamstring exposed, which is for the lengthening of the hamstring. This picture shows the adductor tenotomy and release of the adductor fascia. In this, there is the flexion lengthening of epinoneotic tendon of gastrocnemius, which is give inverted V-shaped incision. There is a posterior tibial tendon transfer, which is attached at the third cuneiform. Results is a gross motor first score in the pre or post operative period. In my study, there is a mainly involved the level 4 and level 3, which is improved at least one level in all the cases. This is the Gupta et al. Soft tissue surgery in lower limbs, which is also involved in the group 4 and group level 3, which is also increased in the level. We have seen the pre-surgery 3 months and 6 months at the patients, which is improvement on the level at least 1 on each series. The range of the movements of the all operative joints improved post-operative. Recently is significantly improved in the posture and sitting and gait and hygiene of the patient. Of the 20 patients who could not walk, 10 could On that, 10 could be ambulated with the use of walker and crutches post-operatively. The mean pre- or post-operative gross motor function classification system scores were 3.15, which is and 1.85 respectively. All the patients saw the improvement of at least one gross motor function classification system score. Complication, there is no intraoperative complication has seen, but 2 cases had developed stiff knee gait at the 3 months of follow-up, both being from non-walker groups. On the conclusion, that is a symmetrical multi-level operation should be performed when necessary. For a single stage and symmetrical multi-level muscle tender surgical application have definitely advantage of a stage intervention. It decreases the morbidity of the patient and the stay of the patient on the hospital stay and rehabilitations. In developing countries like India, single-stage multiple soft tissue is proved to be cost-effective and logistic approach. For achieve satisfactory result, it should be team effort of the surgeon and rehabilitation unit. Thank you.
The paper is now open for discussion. If there are any questions from the audience.
Yeah. You do adductor tenotomy.
Yes, sir.
With that, you do some anterior branch of the upper neurotomy or not?
No, sir.
You are not doing. Sometimes you don't have problems.
Sir, when mainly we have to do the adductor long fascia, mainly have to be cut out. After that, we have to release the hamstring tendon release. So that's why the optator nerve may not go through the optator nerve, sir. Distally 1/3 have to go to the adductor fascia.
Second thing, you are giving the intrathecal baclofen. How does it help?
Sir, it is mainly given by the physiotherapists. In our study, I have given the soft tissue surgery, sir, mainly multiple soft tissue.
You have
Not given. That is given by the rehabilitation physiotherapist, which is given background. After that, they not improve it. We come to the patient to the orthopedician, then we have to give soft tissue.
Okay, thank you.
Thank you.
Next is the tuberculous rectal.
Good afternoon, everybody. I am presenting our experience regarding tuberculosis of SI joint, a neglected differential of refractory low back pain in a series of 25 patients. Sacroiliac joint is involved in 5 to 8% cases of the osteoarticular tuberculosis. The diagnosis of SI joint TB is often delayed due to its presentation as vague back pain, and plain radiographs are usually normal, and the SI joint involvement is very rare in all osteoarticular tuberculosis. So this differential is not usually concerned by the treating clinician. We present here a series of 25 patients presented with sacroiliac tuberculosis. This was started as a thesis case with a prospective study which was performed from January 2008 to December 2011 with a minimum follow-up of 2 years. A thorough clinical examination was done in all the patients complaining of low backache for more than 6 weeks. The examination included detailed examination of back, hip joint, bilateral SI joints, and with neurological examination. Tests for SI joint included tenderness over bilateral SI joints, stress tests like pelvic compression test, the flexion, abduction, external rotation test, as well as the Jensen's test. Blood and radiological investigations were done, in which we found these tests to be positive, and CBC with ESR, baseline LFT, KFT, along with MON2 were the initial lab investigations for every patient who had the complaint of low backache for more than 6 weeks, plus the above test positive, clinical test positive. Radiological examination included AP and oblique views of pelvis with bilateral hip and MRI of bilateral SI joints. Cases which showed lesion in SI region in the radiological investigations were subjected to USG guided needle biopsy for the lesion. The material obtained was sent for histopathological examination, pus culture sensitivity, gram stain, AFB stain, as well as culture in Algae medium. Patients with histopath or culture proven tuberculosis were started on anti-tubercular therapy for 18 months. The 4-drug therapy was started, then depending on the response and the decline in ESR, the drugs were subsequently decreased, and the total duration of 18 months was completed. Patients were kept on complete bed rest for initial 3 to 6 weeks, and considering the improvement with relief in pain, the patient was mobilized on crutch-assisted walking, and follow-up X-rays were done on 3 months, 6 months, 12 months, and 18 months. Most of the patients, out of 25 patients, 91% patient had unilateral involvement of the SI joint. There were 15 male patients and 10 female patients with mean age of 27 years. The duration of symptoms in the patient were ranging from the 11 weeks to 39 weeks, mean 18 weeks. Most of these patients were misdiagnosed by previous treating orthopedician or general clinician as chronic low backache, sciatica, or general postural pain. Persistent low back pain and difficulty with walking were noted in all the patients. 2 patients presented with abscess over the gluteal region. 12 patients had constitutional symptoms involving loss of weight, poor appetite, and night sweats. But in general, the patients were with SI joint TB are, good looking, good with well appearance, not like general TB patients. In our study, nearly 48% of our patients did not have any constitutional symptoms. Clinical examination revealed tenderness along the affected SI joint in all the patients. Stress tests of SI joint like compression test or flexion abduction external rotation test or Jensen's test were positive. Flexion abduction external rotation test was found to be most sensitive in diagnosing the SI joint involvement. The SLR was negative in 18 patients, that is more than 72% patients. ESR was elevated in most of the patients. AP and oblique views were ordered for all the patients. The features on X-rays included widening of joint space, sclerosis of joint margins, as well as periarticular osteopenia. The oblique X-rays were particularly important because many AP views, X-ray of pelvis were normal on AP view, but the findings were obvious in oblique views. So the oblique X-ray are particularly important in diagnosing SI joint TB. Radiographs were, however, not always helpful, as I said. MRI was very useful in such cases as it not only showed the bony involvement but also the surrounding soft tissue involvement or any abscess around that region. This is the picture showing involvement of left SI joint. The radiograph shows the involvement of SI joint, and the corresponding MRI in T2 film shows the collection of around the SI joint. In this view, the AP view shows the normal findings, but in the oblique view, we can find the widening of joint space as well as the periarticular osteopenia. And all patients, the histopathology, the USG guided material was sent for histopathological examination. It suggested tuberculosis, the caseous necrosis surrounded by epithelial granuloma. The stains for AFB was positive only in 14 patients, and only 3 patients showed the growth on LJ medium. Results of TB treated with NTT was satisfactory. Pain decreased by 2 to 3 months. ESR was reduced and came to within normal limit in 6 to 9 months. Radiological healing, however, was not corresponding with the clinical healing. Patients were symptomatically better on ATT much before the radiological signs of healing could be demonstrated. Most of the patients, however, had mild discomfort after end of the treatment protocol. This is the before and after treatment X-rays of the patient. And the take-home message: most of the patients present with chronic back pains, SITB must be kept as differential in all the refractory low back pains, particularly in endemic area like in India. Clinical diagnosis of SI joint infection includes a thorough history and meticulous examination of lower back along with the SI joint. MRI is very helpful in early diagnosis of disease, and in early stages of infection, aspiration using a closed needle biopsy is recommended. ATT of 18 months is usually sufficient. Thank you.
Yeah, now paper is open for discussion. Any question?
What is the externality plan? Keeping the patients on complete bed rest for 3 to 6 weeks?
Initially, most of the patients what we observed were complaining of pain, low backache for more than 6 weeks. The initial bed rest was to subside the inflammation around this SI joint. The walking aggravated the pain. So, depending on the response of the patient, 3 to 6 weeks rest was, yeah,
Bed rest was for pain only.
for pain only.
Continue down with any pain because patient in SI joint pain and tenderness. Again, already having 6 weeks of history. Again, we are keeping the patient for complete bed rest for 6 weeks.
Along with the analgesics and start of ATT.
You are starting ATT at what then? The patient has come to you.
Yeah.
He has low back pain, communicated outside.
Yeah.
Now, what is the criteria for starting the ATT in that particular patient? You are suspecting SI joint
Yeah.
tuberculosis.
Yeah.
You are just suspecting, but you are not starting the ATT. Right?
No, no.
You are not starting. So when you will start ATT for SI joint, particularly for not for?
For SI joint, after confirming the reports like histopath or AFB or. No, no, no. We are not waiting for LG medium to grow, but on the histopath or AFB stain, we'll start after that review. Yeah.
Any question more? So your complete bed rest means he cannot go to the toilet and other things, sir. He can go to the toilet and not. With some orthotic supports.
Yeah, I mean, as much as the lifestyle of the patient suffices, maximum rest as much as possible. He can go to bathroom and daily activities, but the professional activities or any job activities should be, if possible, it should be restricted.
Do you come some orthotic supports also?
No, no, no.
Belts, something.
Any
supports?
In 1 to 2 patients, they already had the LS belt, but we didn't advise separately the belt.
Okay, thank you. Next is the floating shoulder.
About the floating shoulder. Coming to the introduction part, a floating shoulder is defined by ipsilateral clavicular fracture and scapular neck fracture. The distal fragment as glenoid and coracoid is connected to the proximal fragment, the acromion, scapular, spine and body by the coracoclavicular and coracoacromial ligaments. These all together forms a bony and soft tissue ring which is called as superior shoulder suspensory complex. The term was introduced by Herskovitsky, and the mechanism of injuries in such type of fractures is fall on the tip of the shoulder, direct blow, or fall on the outstretched hand. Now coming to our case, a 35-year-old male patient presented with road traffic accident and sustained injury to the shoulder, chest, and elbow. These fractures are usually associated with spine fractures, hemothorax, and pneumothorax. But our patient was lucky as he didn't have anything else. This is a clavicle fracture, glenoid, and this is the distal humerus fracture. So we performed open reduction with pre-contour plate for clavicle fracture, open reduction with recon plates for scapula, and open reduction with small DCBs for the distal humerus fracture. These are the post-operative X-rays. And post-operative rehabilitation, immediately post-op shoulder arm strapping was done. After 1 week, universal shoulder immobilization was given with intermittent pendulum exercises and elbow mobilization exercises. Sutures were removed at 14 post-operative day, and after 3rd week, shoulder mobilization exercises were started. So these are the follow-up X-rays. All the fractures got united, and these are the post-operative range of motions we achieved after 1 year of follow-up. So coming to the conclusion, this missing of glenoid fractures in polytrauma patient is high, so very high level of suspicion is required to find out these fractures. And surgical management in displaced fractures allows early rehabilitation and full functional range of motion and early rehabilitation. Thank you.
Any question, please? Now,
which approach you use to fix these scapular fractures? Can you go back if there is any slide?
No, sir. Per-operative slide I didn't have.
No per-operative. So which approach was used to fix these?
Posterior approach, sir. We have to lift the deltoid, and the muscle plane is between infraspinatus and teres minor. That's the approach.
Okay, thank you. If any questions from the audience? So if...
yes. Yes. Yes, sir.
All these injuries are together. Is it important to fix all of them, or one can be fixed and other can be fixed conservatively?
Sir, there is literature that if even clavicle fracture is fixed, that will reduce glenoid fractures. But if we have to see per-operative under CM that these are not reduced. If there is a ligament disruption, then it will not reduce. Then we have to go for glenoid fracture fixation, sir. No, sir, we started intermittent mobilization after 1 week only. Abduction and all we start after 3 weeks.
So, thank you, Dr. Arif, for your good case report. Now, next speaker is Dr.
I'm going to share our experience of orthodesis of the knee by Elizaro method. Coming to brief history. The brief history, in 1878, Professor Albert of Vienna performed knee orthodesis because of the instability of the knee in case of poliomyelitis. In 1911, Hibbs orthodesized the TB knee. In 1948, Sir John Charnley introduced external fixator for orthodesis, knee orthodesis. And in 1948, Kapkel introduced Kunshan nail for knee fusion. Coming to methods, it can be fixed both, knee orthodesis can be done both internally and externally. Internally by intramedullary nailing, plates and screw fixation. And external fixator by these methods, Charnley, LRS, Elizaro, and AOX fix external fixator. These are the pictures showing it. We did by Elizaro method. This is the nailing, this is intramedullary nailing, and this is the LRS and AOX fix thing. Coming to our series, in our series there was total 17 patients, out of which most common was one was the septic arthritis of the knee, which included in that most common was the infected TKR. Second most common cause was the giant cell tumor, 4 cases, and remaining were traumatic crush injury, burn contracture, soft tissue sarcoma, and infected arthrodesis. This is the graph presenting pie chart representing the same thing, septic arthritis, which was the most common cause. In that septic arthritis, infected TKI was it included 6 cases, post-traumatic infection 1 case, and pyogenic arthritis included 1 case. This is the brief master chart of my cases which we have performed. Coming to material and methods, there were 9 males and 8 females. Average age was between 20 to 80 years, and age was between 20 to 80 years, and average age was 41 years. Coming to our cases, this is Premila. She had which become infected, and we performed. This is the pre-op X-ray, which shows tricompartmental osteoarthritis, for which we did TKR. This got infected, and first we removed the implant. Then we put the antibiotic spacer. And this is the picture after the removal of the spacer. This is the clinical picture showing the infection. And this is the post-op X-ray after orthodesis. Coming to second case, this is the giant cell tumor of the lateral condyle of right tibia. This is a lesion, lytic lesion, which you can see. And we for this case. But after that, it recurred again. So we did, this is the clinical picture showing the swelling here. This is the peroperative picture of the same thing. For this, we did resection of the first tumor mass, then we did orthodesis, and we did it by Elizaro external fixation, and we did the proximal tibial corticotomy in order to gain the length. This is the post-op X-rays, which is showing the fusion. This is 2 years after the 2 years follow-up, showing good union. This is showing the good regenerate, which we performed the corticotomy there. This is the final post-op X-ray. One more case, Chennamma. She had giant cell tumor of the right distal tumor, clinical photo. This is the CT scan of the same thing, distal femur ECT. For this patient, we did resection, orthodesis, and limb lengthening. There was actually 15 centimeter of shortening. So we performed 2 corticotomies in femur and 1 in tibia at first setting, followed by 2 more corticotomies in the tibia second setting. This is the pre-op images, Elizaro ring application, and this is the final image. This is the image immediate post-op showing the removal of the mass and application of the Elizaro fixator and corticotomies in the femur. And this is in the tibia. This is the picture showing good regenerate in the proximal femur and distal femur. This is the arthrodesis and the proximal femur regenerate. This is the same thing, follow-up. This patient had developed equinovarus for which we did extension of the fixator to include the foot also, foot piece. This is the one more case, comminuted distal femur fracture, open fracture, for which we did Elizaro and simultaneously corticotomy also for limb lengthening. This is at removal, showing good fusion. One more case, lateral condyle of the left femur giant cell tumor, same thing. We did resection orthodesis and limb lengthening. This is at 9 months. This is at the time of removal, after removal. We put him on the HKFO. Coming to the results, we achieved a knee fusion in 12 cases. But we did bone knee amputation in 2 cases in which the septic arthritis was not controlled, uncontrolled septic arthritis. In 3 patients, fixator has to be removed. We are waiting for the thing. This is the chart showing the same thing. 3 persons are waiting for the removal. Limb lengthening we did in 6 patients. So average was, maximum was 17 centimeters of shortening and minimum was 6 centimeter. Average lengthening we gained was 11 centimeter. Coming to few papers which support the Elizaro external fixator frame in compression orthodesis of large weight-bearing joints by Edward and Caliph. He says that primary orthodesis has been advocated as the treatment of choice for severe intra-articular fractures, where both soft tissue, bone and soft tissue injuries are so extensive as to preclude the anatomical restoration of articular surfaces. This is the journal of JBGS journal, which shows this journal said by H.J. Ostenbrock. He treated 15 patients by orthodesis of the knee after removal of an infected total knee arthroplasty using Elizaro external fixator. This is one more paper which also showed that all patients could walk without walking aids except for one patient who further required lengthening for marked shortening due to previous wide tumor resection. Coming to review of literature, according to Chanley, who performed using Chanley apparatus, 98.5% rate of fusion in 67 cases with primary orthodesis, and Puranan's 96% fusion rate with intermedullary fixation. Coming to conclusion of my study, Elizaro external fixator, it's a good device for knee arthrodesis due to the following advantages which it has. One is it gives stable fixation, it causes early mobilization and weight bearing. Third is correction of deformity, and main thing is the limb lengthening, which can be achieved simultaneously, and finally control of the infection. Thank you.
Now the paper is open for discussion. Any questions from the audience? So if there are no questions, now I invite Dr. R.A. Agrawal to present his paper. Thank you, Dr. Bimal, for your good presentation.
Yeah, Mr. Chairman, my topic is the comparison of the results of iliac crest medial opening wedge in high tibial osteotomy, along with the results of the iliac crest wedge, along with the fibular pillar and 1.5 centimeter fibular removal to treat medial compartment osteoarthritis. This is a very new subject. There had been many treatments for the osteoarthritis of the knee. So we thought, for example, this is the pillar. Fibula is the pillar. So there can be nothing into the fibula. You will get the below that the छज्जा जो निकलता है उसी में problem आती है. So as soon as the fibula strand is like pillar, it does not allow the correct the genovirus deformity. So we have taken for the lot of biomechanical studies, we found that we have taken the length of the tibia on the medial side, it comes less in comparison to normal that. But the fibula is stand there. Until and unless we have done the biomechanical studies, until and unless you will not do the less size of the fibula, there is a lot of recurrence there. Osteoarthritis knee, most common degenerative disease of mankind. Medial compartment is affected more commonly even in the younger patients. Dome osteotomy was described as Beckett, then Jackson and Watt. There are two types of osteotomy, focal dome and the dome osteotomy. You go to the history, Jackson and Watt, 1961, osteotomy distal to tibial tuberosity. Some say closed osteotomy proximal to distal core distal McQuaid, both osteotomy proximal to the tibial tuberosity but distal to cora. There is a lot of confusion where should be the osteotomy. If you go to the biomechanics, normal knee loads, they are 2 to 4 times of the body weight are imposed on the knee joint. 60% of this load passes through the medial compartment. In genovirus, more load is imposed on the medial compartment. Preoperative planning is the physical examination, range of movement, knee stability, Q angle, any foot and ankle deformity, leg length discrepancy, preoperative photographs and video. You have to take the long X-ray to affect the angle of the varus. And after the osteotomy, your line to mechanical axis line should passes through the PG is a point that is divided into 0 to 100. So this line should pass the mechanical axis, 2 to 3 degree more than normal. This is a middle lady, this old lady. She came to us with a very severe deformity. You can see there. So she was very much afraid of the total knee joint. So we thought to save this joint. And you can see this is the final. We are having the 5 years of the follow-up. She has been, her age is about 68 years or 70 years most probably. But she has been totally treated. So her 35 degree was the varus was there on both the knee joints. What we have done? We have done the osteotomy. We have gained a parapatellar here incision. Open this thing. And what we have done the open ways and we have put the chronos and after that. So what we have find out that usually the result failure is because these patients have the flexion deformity. So what we have done, we have taken 1.5 centimeter fibula from here and we put on the posterior side of the, this is the posterior side. So we have done the chronos and the fibula which we have put on the posterior. It works like a pillar there. And because we have removed this, so when she was walking, it was giving the valgus thrust. So there was a recurrence of no recurrence of the deformity. So you can see this lady, final movie. Hello. Yeah. You can see its final movie. So the deformity has been fully corrected. So we can save her knee joint, which was used to be the knee joint. So it gives an excellent treatment. So there is another lady in which we have done the same thing. You can see that how beautifully there is a regeneration of the cartilage. That is mentioned by Kosani. He has shown that when we valgus thrust, if you put the load more to the 10 degrees, so that normal is the 6 degree. If you put the 4 degrees, the thrust is here. So Kosani has showed a Japanese worker who was doing for the last 15, 20 years. There is a regeneration. You can see that the joint was here like this, here. Now this joint has come, there is a regeneration of the joint. There is another lady who has developed this 10 degree of varus. But in that we have taken the cancellous celiac bone graft. But later on we found that this bone graft is very weak. And there was a recurrence of the deformity. Initially we used to take the your bone graft, but now we are not doing that. So at the bones were osteoporous, there was a recurrence of the varus deformity in some of the cases. So our protocol is now chronos and the fibula osteotomy, resection of the fibula. Regular follow-up at 2 weeks per suture removal, thereafter monthly interval. Full length radiographs should be taken. Advantage, adjustability, large bone-to-bone contact, stability, technically difficult in compatibility with rotation correction. Knee stiffness, loss of correction, delayed union osteotomy site. Total number was 34 and the anatomical correction average was 6 degree genu valgus. Advantages: full tune adjustment to get optimum results, full weight gearing after 12 weeks, no bone graft harvest site as chronome can be used. Controversies in high tibial osteotomy: the osteotomy above or below tuberosity, fibula osteotomy, a resection of 2 centimeter fibula, fixation method external or internal. Conclusion: medial opening wedge in high tibial osteotomy with chronome and 1.5 centimeter fibula related to teeth. Medial compartment osteoarthritis in knee is an effective, safe, and cheap alternative treatment of osteoarthritis knee. Less chances of recurrence. Patient is mobile throughout the treatment. Thank you very much.
Thank you, Dr. Ramotar Agrawal, for your excellent presentation. Any questions from the audience? It's a very interesting paper.
No. First, what we do, we keep about 4 to 6 weeks of the plaster fixation. With the tomofix? No. Actually, what we say, our protocol is like that. For 3 to 4 weeks, when we don't allow to walk, we don't give any plaster. But after 6 weeks, we allow for the weight bearing. Because in the old age, the bones are osteoporous. So after 6 weeks, for the first 4 to 6 weeks, just bandage and other things they use to exercise it. But after 6 weeks, we allow to walk to these patients, then they walk with the plaster for 6 weeks. Iliac crest, I told there are two biomechanisms, we go with that. Actually, iliac crest used to be the collapse because these are the osteoporous bone. For that, we have taken the chronos. Number 2, because fibula is the like pillar laterally. So if you resect the fibula, when they walk, they will give the valgus thrust there. So there were two functions. Number 1, if you examine all the cases, you have examined many cases, then we have find out all the cases have the flexion deformity. And even after the surgery, they develop the flexion deformity and they have having poor results. To overcome that, because whatever correction, whatever exercise you do, when you are going to operate these cases, you will find there 5 to 10 degree flexion deformity remains. So if you do that, so we put the fibula pillar, the amount of the resection will be degree. If it is 15 degree, 1.5 centimeter, it is more than 2 centimeter, depends on how much. So it gives the posterior stability. And number 2, biomechanically we can find out that we have studied many cases of the genovarus deformity. The length of the tibia on the medial side is less because due to compression of the tibia. So that if you remove the fibula, when they walk, it gives thrust to the lateral side, so that there is very good regeneration of the cartilage and there is no recurrence of the deformity. No. We always correct the 2 to 4 degree of the overcorrection. Normal it is 6 degree, so we go to 8 to 10 degree correction. Actually, initially we were not doing the bilateral, but as soon as we get acquainted with the techniques, only thing is the load bearing will be a little late. So we have started to do the bilateral because we don't take the graft from the iliac crest. That is the most important because many cases we got failure. Because in these age the bones are very weak, they got the recurrence of the deformity because where we fix the plate, even that they can't hold the screws. So it is very necessary you will take the hydroexercise chrome and we are now doing bilateral. Yeah, mobilize later 8 weeks or something like with the crutches and others. First when they walk, because we have fixed with the plate, so post-operatively we don't need the plaster. But because the bones are weak, the screw cannot hold the screws. So when they walk, when you apply a cylinder cast, and sometimes synthetic cast bivalve, when they walk, they can hold that the molds, and after that they can do the exercise. Yeah. it's become problematic. But I tell you, if we operate one of the cases, most of the cases, one side, for 1 year they don't come at all. They walk with the varus knee on the another side. So what happens? Again develop the deformity. That is the problem. So in India, they don't walk the 6 to 8, it hardly matters because the people have to serve them. So I think then it's easy to get rid of the deformity.
Dr. Agrawal, where do you make the incision? Can you exactly describe me?
We don't go on the medial side at all. Because medial side, we have to put the plate. So what we do from the osteotomy side, about 4 finger width below, we start the incision from the skin of the tibia. Then we go lateral to the tibial tuberosity and the patella, and we reach up to the joint line. Because these are the old cases, so we get a lot of fibrosis. So by periosteum elevator, even we go up to the second thing is we go up to lateral side. So we go the incision on lateral side. Second thing I tell you very important. When you are doing the osteotomy, last about 1/8 portion of the tibia should not be broken. It works like a hinge. So you should be very conscious under the image intensifier. If you have broken the tibia full, the fragment will go, I don't know, somewhere else. So it's very important. The last, you can have this article, we have this article. So last tibial lateral side, you will not cut it. So incision is lateral side. This was the work of Kosani. He has done this work from last 20-25 years. He says always, when one teeth is spoiled, why take all 32 teeth? So he is very much against the TKR. He said in the all over the world, the 50 to 60% of TKR which are being, they can be saved by this technique. We were also doing the Ilijarab, but after the 60 year, it is very painful. Wires don't hold. So we make protocol like this. If the person want to have the below the 60 year, we can do the Ilijarab. Otherwise, this technique is excellent. You can operate, but many patients died also. They got infection, they got the loosening of the wires, because the upper ends, they are very weak, and they are very painful also. So now we are not doing about 60, 65 years. Complication actually, what happened, initially we have done the fibula resection 10 centimeters below the head of the fibula. So in one of the cases, there is an injury to the branch of the peroneal nerve. So then I've gone to literature. He says that you should not do upper. It will be the middle fibula resection. So one of the cases we thought, because here is the deformity, so we should take the fibula. But now I've gone to the literature and I personally asked him, so you may damage the anterior branch of the peroneal nerve. So we do superficial peroneal nerve. So we do in the middle, resect in the middle. Otherwise, I tell you, now, Tomofix is made by the AO people. Now, many companies, like Green Surgical, they are making this. I got this workshop in Bombay. So I purchased the plate. I have gone to Baroda, and we developed this plate. I stayed for 4 or 5 days, because it's a very cheaply in titanium. AO plates are very costly. So you can use this technique. This is a wonderful technique. Till now, all the procedures which I have done, I found this is a wonderful technique. Thank you.
Thank you, Dr. Agrawal, for a very nice presentation. Osteoarthrosis is a very common problem in our country and is a good solution. So thanks a lot. Now,
the study which is done in a trauma center, autologous platelet-rich plasma precipitate, a regenerative therapy in wound healing. So wound healing is a complex process which is mediated by a lot of interacting of molecules. So why the wound doesn't heal? If it is not healing, we call it as a chronic wound. This may be due to the impact of an injury of the soft tissues, or it may be due to the dehiscence after surgery. And there are some factors like advanced age, trauma, and diseases like diabetes, infection, and medications. They all alter the effective of wound healing. So there are so many ways of healing these processes, like back dressings and repeated debridements. So we have an alternative way of thinking, like why not we inject a platelet-rich plasma in a higher concentration in these wound margins for effect of wound healing. So what is platelet-rich plasma is the higher concentration of platelets than the baseline. That is around more than 5 to 9 times the baseline. So this platelet-rich plasma has been a breakthrough in stimulation and acceleration of bone and soft tissue healing. So our objectives of studies are the role of the local infiltration of platelet-rich plasma in wound healing. So we had done 15 cases and still we are doing it, and we are doing as a prospective study. In our inclusion criteria, the age group is around 20 to 60 years of both the sexes. And the patient who is having a chronic large surface wounds and wounds that fail to heal in normal dressings. And the patient having the blood platelets more than 1,50,000. The exclusion criteria are the patient on antiplatelet therapy and the platelets less than 1,50,000, and the patient not willing to donate blood, and known bleeding disorder and liver diseases, the patient on shock or septicemia. How to prepare this PRPP? The patient has to donate his own blood. That is, 1 unit of whole blood will be drawn on the same day. So the patient has to be transferred to the blood bank. 1 unit of blood will be drawn, and the centrifuging will be done. The first centrifuge will be done by 5,000 rate per minute in 17 degrees Celsius in 30 minutes, and the second centrifuge will be done in 1,500 rate per minute in 17 degrees Celsius for another 15 minutes, and we will be getting an ultra concentrate of around 30 to 40 ml. And this ultra concentrate is packed in sterile bags, and this will be injected to the patient on the same day of the OT. The rest of the preparations, the RBC, will be reinfused to the patient on the day of procedure. So this is a centrifuge machine which you have in our blood bank. So the amount of, this is the platelets which is in the buffy coat, and the plasma which is also having some of the platelets. So we have this platelet-rich plasma. We pack it in the sterile bags, and in the OT, after the proper debridement with a 16 gauge needle, we will be injecting the platelet-rich plasma precipitate along the margins and along the base of the wound. So the wound assessment, we will be preoperatively and post-operatively we will be assessing the wound margins. So the evaluation after the procedure will be done every 48 hours. And in every dressing, we will be using only saline dressing. We don't use any antibiotics or antiseptics. So the wound culture will be done every 2 weeks. And in the evaluation, the size, depth of the wound will be measured in all the margins like 3 o'clock, 6 o'clock, 9 o'clock, and 12 o'clock, and will be summed together. And we also calculate the amount of granulation, the presence and absence of infection, the time period between the infection and the final closure, either it may be a flap or a grafting. So the results in which our analysis of the results in our study, the patients, or the 15 patients we analyzed, the average blood platelets in those patients were around 1,56,000 to 2,40,000, and in the concentrate it was around 2.5 into 10 power 6. The average dimension of the wound which we had included, we had done still till age is around 11 into 10 into 1.2. Only single injection of platelet-rich plasma precipitate will be given, and the average time gap which we had till now between the injection and the time gap between the closure, either may be a flap or a grafting, is 10 days. So the average reduction of the wound size from its original size is around 80% in 12 days. There is no recurrences seen, and we have not taken any patient for any repeat debridements in these days. And there is no infection in the post-injection period. So we also had 4 patients pre-operative. They had some infections, like one patient had Pseudomonas, and 3 of us patient has low-grade Acinetobacter. And post-procedure, the patient the culture seems to be negative, and there is no immune reactions noted. In discussion, the chronic non-healing wounds present as a formidable challenge and require individualized therapy to give the best opportunity for the wound closure. The platelet contains alpha-beta granules, in which the alpha granules having lots of growth factors like PGDF, transformic growth factors, and vascular endothelial growth factors, epidermal growth factors, and insulin growth factors, which is important in wound healing. So by injecting these growth factors locally along the wound margins, so the wound healing will be better. So this PRPP initiates the wound repair by releasing the locally active growth factors. Also, it fights infections by recruiting white blood cells, which is released from the bactericidal factors. It is autologous, so there is no immune reactions noted. So these are some of the examples. This is a case in which we have the large surface area in the pre-procedure, and after injection, this is a day 6, and this is a day 10, and this is day 12, and this is day 18, and at the end of day 30. In the next case is the patient who had a dehiscence of wound. This is a pre-procedure, and this is in the day 2, and this is day 8, and this is day 10. And we don't have any grafting of this procedure. The wound healing done by his own, and these are 3 weeks follow-up. The lack in this our study is there is a less number of cases, and we don't have any control group, and the volume of blood donation and the PRPP volume has to be quantified. So the conclusion is the patient having a better and earlier wound healing and closure. It has a decreased infection rate. It is cost effective without any complication, and the PRPP is autologous, and there is no immune reactions noted. Thank you.
Thank you, Dr. Senthil. Now the paper is open to discussion. If there are any questions from the audience, please.
Yes, sir. Yes, sir. Neurogenic wounds. So we are trying, this study is only on the wounds that is on the fractures, generally the fractures. But we are having another part of a study in which we are using in the bed sores and also on the pressure sores and venous ulcers also. And the literature also having a proof like it was started in healing of the diabetic ulcers, which is having a poor neuropathic ulcers of diabetes and leprosy. So from the success rates, this has been evaluated in different stages of medicines and surgery. So we had included in this study in our open fractures and dehiscences, since we have lots of cases which come to our trauma center as open fractures. So we have a greatest difficulty in discharging those patients. So we need an earlier closure of those patients. So instead of daily debridement and sending the patient daily to OT, so we have a trial of these PRPP in those fractures, in those wounds. Yes, sir. Yes, sir. Yeah. Yes, sir. No, we are having a blood bank facility. So whichever hospital which has a blood bank facility will be having the centrifuge machine, and this is a normal centrifuge machine that separates the blood products into RBCs, platelets, and the rest of the plasma. So we can get the platelet-rich plasma from the same centrifuge machine also. It depends upon the rate, the centrifuging time and degree, amount of the centrifuging. First is 5,000 and next is 1,500. No, sir. No. We can give, but literature doesn't have any proof of giving those patients. This is our first pilot study. So we are doing it in autologous thing first. And from our success, then we go for the next step ahead.
So thank you, Dr. Senthil.
When these are the open wounds,
Yes, sir.
so how you put that platelets?
So we first fix the fracture, and once we see that there is a wound dehiscence, or then the wound is not healing by its normal way, then we select the patient in an inclusion group. We shift the patient to the blood bank. We donate blood. The patient has to donate the blood, and the same day, patient will be shifted to OT. We debride it, and we inject the platelets along the local margins.
Then my question is, the wound is open.
Yes, sir.
So whatever platelets you will put that, they will fall off in the dressings. That
No,
is my
we'll
question.
infiltrate it. We'll infiltrate it.
Injecting.
We are infiltrating it.
How much taking you amount? 50 ml.
The patient will be donating 1 unit of blood, and we will be getting around 30 to 40 ml.
Okay.
So the next speaker is Dr. Kumar Keshav.
Good afternoon, Chairperson, sir, and respected audience. My paper is about simple curettage and bone grafting by synthetic calcium hydroxyapatite in various benign lytic lesions of bone. First of all, a brief introduction. The various benign lytic lesions of bone that you all know, simple bone cysts and usual bone cysts, fibrous dysplasia, giant cell tumor, and Brown's tumor of hyperparathyroidism, to name some of them. There was an article published in this journal, Derchur, about the treatment concepts of benign bone tumors and tumor-like bone lesions, where it is mentioned that for most benign tumors, intralesional curettage and subsequent bone grafting is the treatment of choice. The biological mechanisms of bone grafting includes osteogenesis, osteoconduction, and osteoinduction. As you can see in this table that autografts have got all the three properties, osteoconduction, induction, and osteogenesis. On the other hand, hydroxyapatite has got only osteoconductive property. And that is why the speed of both bone ingrowth and repair depend on the host and the delivery of osteoconductive mediators. The synthetic hydroxyapatite is slower to resorb than the endogenous form and may stay at the site of implantation for many years. The hydroxyapatite scaffold is brittle and carries little tensile strength, and hence load bearing should be delayed until evidence of graft consolidation is present. We carried a study, the aim of which was to evaluate and assess the role of hydroxyapatite as a bone graft substitute in filling voids after curettage of benign lytic lesions of bone, and to find out the outcomes of treatment, complications, and the advantages and disadvantages of hydroxyapatite in benign lytic lesions. The study was conducted in the Department of Orthopedics, GSVM Medical College, Kanpur, during the period 2006 to 2014. The benign tumors confined to the anatomical limits of the bone, with or without pathological fracture, were included in the study, and the tumors which were either very large, or there was any active infection, or there was any suspected or diagnosed malignant lesion, or there was any traumatic bone loss, were excluded from the study. With this inclusion and exclusion criteria, 57 patients were enrolled whose age ranged from 3 to 55 years. This is our management protocol, which consisted of detailed history and clinical examination, followed by investigations in the form of radiological investigations of the affected part, hematological investigations, and the FNAC, nil biopsy, or core biopsy, open biopsy, which were possible. Followed by surgical intervention. The surgical intervention was in the form of curettage and bone grafting by synthetic calcium hydroxyapatite. The synthetic calcium hydroxyapatite that we used in our study was of G-Bone Surgivier company. Then the patient underwent check X-ray, and the patient were kept in regular postoperative follow-up, first at 6 weeks, then at 3 months, then at every 3 months, and after 1 year at every 6 months. A few words about surgical intervention of our procedure. Standard surgical approaches and principles were followed. A cortical window was made. Thorough intralesional simple curettage was done. The cavity was washed with hydrogen peroxide, followed by copious amount of normal saline. A sterile packing gauze was insinuated into the defect to remove any tissue of tumor that would have been left unknowingly. Then the lesion was packed with synthetic hydroxyapatite, G-bone. Intraoperative fluoroscopy was done to see that no void has been left out. After packing the defect, either the periosteum was meticulously reapposed, or the soft tissue coverage was done when the periosteal coverage was not possible. And the best possible care was taken not to allow any pieces of G-bone in the subcutaneous plane. The curated material was sent for histopathological examination. Some of the patients who presented with fractures underwent either an external or internal fixation. And some form of protective splinter was applied postoperatively, depending on the site and size of the lesion. The radiological evaluation of graft incorporation was done according to the Irwin's criteria, which included 3 parameters: the radiological zone between the bone cavity and the graft, the intrinsic graft indistinctiveness, and the graft margins. Now the observations. Most of the patients belong to 10 to 30 years of age, followed by 20 to 30 years. There was no patient aging more than 60 years. Males and females were in a ratio of 2:1. The various sites of lytic lesions in our study included proximal femur 10 cases, followed by proximal humerus 9 cases, proximal tibia 8 cases, and there were 6 cases each of distal radius and distal femur. Now the duration of follow-up. Out of the 57 patients, 8 had a follow-up of more than 5 years, 4 had a follow-up between 3 to 4 and between 4 to 5 years. And most of the patients, 12 patients had a follow-up of 1 to 2 years. There were 7 patients having very short follow-up period of less than 3 months. At the end of final follow-up, the radiological staging were seen in the form of stage 3, 55% cases, 31% cases in stage 2, and 14% in stage 1. The complications seen in our study were recurrence 4 cases, discharging sinus with infection in 3, pathological fracture was seen in 1 case, there was restriction of motion of nearby joint in 6 cases, and deformity appeared in 4 cases. There was no case of graft rejection. The final outcome can be summarized as excellent in 81%, good in 7%, fair in 3, and there were 9 cases of failures. We have relationship between radiological staging at final follow-up and various factors, and in this we have found a significant association between radiological staging at final follow-up and duration of follow-up, when 2 years was taken as a cutoff, the p-value being less than 0.001. Now I'd like to show some clinical cases. This is a patient of simple bone cyst of the proximal femur. You can see that there is a lytic lesion in the neck and the trochanteric region. This is immediate post-op X-ray and then the subsequent follow-ups. And the final follow-up at 2 years. As you can see, the graft has got incorporated in the bone. This is a patient of giant cell tumor of the proximal tibia, 25-year female patient. This is pre-op X-ray, followed by the immediate post-op and then subsequent follow-ups. And last follow-up at 2 years. This is a patient who had fibrous dysplasia of the mid-shaft of the humerus. He presented with pathological fracture. So we went for external fixation in the form of GES along with this curettage and G-bone grafting. And these are the subsequent follow-ups. And at the end of 4 years, you can find that there is very less graft remaining there. The radiopacity is very less. This is a patient of solitary lytic lesion of tubercular origin. He was initially started on ATT. Then we went for surgical intervention in the form of curettage and bone grafting. And then later on he had cubitus varus deformity at the grafted site. While playing, he had a fall again, and there was fracture at the grafted site. And we went for LCP fixation in this case. And this is a follow-up at 7.5 years. This is a patient of giant cell tumor of distal end of radius who was going uneventfully, and she had a recurrence at 1 year 3 months. It was detected at 1 year 3 months. And then she underwent fibular grafting along with fixation with K-wire. And this is a post-op X-ray. Now discussion and conclusion. The time taken for bone formation and radiological incorporation. Most of the patients entered Irwin's stage 2 within 3 to 9 months, while reaching stage 3 required around 6 months to an year, even beyond. Faster incorporation was seen among younger patients. Complications were seen in the form of limited range of motion of the nearby joint in 6 cases because of soft tissue adhesions. There was discharging sinus in 3 cases, probably maybe due to